You can get the feed, sir.
Sitesh, you are mute.
Please unmute, sir.
Shall I begin?
Yes, sir.
Okay. A very good evening to all of you. This is Dr. Sitesh Roy. I shall be the moderator for today's session, and it gives me great pleasure to be presenting a topic that I feel is very unique. I believe that this is the need of the hour at this point of time to have this conversation, because the current trends and challenges that we are facing in post-COVID-19 complications is really something that the entire country and all the medical fraternity is dealing with, not just in India, but across the globe. And all the sharing that has occurred of knowledge and information has really helped us better take care of our patients. And I believe that with this webinar, you all should be able to have a better and deeper understanding of what is going on. Just to give you a brief introduction about myself, I'm Dr. Sitesh Roy. I am a clinical immunologist, allergist, and asthma. I practice in Mumbai at my center, Dr. Roy Health Solutions Clinics. I was in America for about 14 years and came back to India in 2011. So I have about 9 years, 9.5 years that I've been practicing right here in Mumbai. Was the ex-director of Dr. Nefardkar's asthma allergy clinic in Dadar. Presently have my own center, Dr. Roy Health Solutions Clinic. I shall now introduce our esteemed panelists. For the pulmonary perspective, we have Dr. Urman Dhruv from Ahmedabad. Cardiology perspective by Dr. Ameya Udyavar from Mumbai. Nephrology perspective, Dr. Jatin Kothari, and neurology perspective by Dr. Malav Gadani. Just for a brief introduction of each of our panelists, Dr. Dhruv is the director of the Department of Internal Medicine and Diabetes at HCG Hospitals, Ahmedabad. He's the recipient of the Gujarat Ratna Gaurav Award by Government of Gujarat. President-elect Research Society of Study of Diabetes, Gujarat Chapter, recipient of the Oration Award by Association of Physicians of Gujarat, and the recipient of Oration Award by Ahmedabad Medical Association. An author of multiple chapters in API Textbook of Medicine and International Textbook of Diabetes. Dr. Ameya is a consultant cardiologist and cardio-electrophysiologist with Hinduja Hospitals in Mahim, Mumbai. He's a consultant cardiologist and electrophysiologist also with Holy Family Hospital in Bandra, Mumbai. He's done his fellowship in cardiac electrophysiology from Taiwan and a fellowship in cardiac devices and electrophysiology from Australia. Again, welcome to Dr. Dhruv and Dr. Ameya. Dr. Jatin Kothari is a consultant nephrologist and transplant physician at Hinduja Hospital in Mumbai, a consultant nephrologist and section coordinator with nephrology in Hinduja Healthcare Mumbai, that's CAR, and the treasurer and trustee at Apex Kidney Foundation Dialysis Networks Centers. Welcome, Dr. Kothari. And Dr. Malav Gadani is a practicing consultant neurophysician in the Department of Neurology in HCG Hospital, Ahmedabad, which is one of the most reputed COVID-designated private hospitals in Ahmedabad. He was a part of the team which had pioneered stroke thrombolysis in tertiary care general hospitals in Gujarat. Welcome, Dr. Gadani. For the topic that we'll be speaking about, a brief introduction. We all know that coronaviruses have been around us, at least known since the 1960s, with many of them causing common cold with change of seasons, especially the cold weather. Then we had the SARS-CoV-2 in 2002-3, which caused severe acute respiratory syndrome, and then the MERS, the Middle East Respiratory Syndrome, which came in 2009, 10, 11, somewhere in 2011, 12, and then we have the novel coronavirus, which is now called SARS-CoV-2, which has come in 2019. Though the SARS-CoV-2 virus is 25 times bigger in size than the SARS virus, it is far more contagious and has one very interesting property, and that is pre- and asymptomatic transmission, as well as a significant stability outside the human body at various temperatures and humidity compared to the SARS virus. There are many other differences, but this is not the platform to go over that. As we know, COVID-19 has shown us a wide spectrum of presentations in which we all recognize the fever, cough, and shortness of breath, but there are myriad of upper respiratory symptoms, including a scratchy, itchy throat, nasal congestion, a loss of smell, loss of taste. Patients can present with just severe body pain, fatigue, myalgia. We can have GI manifestations like diarrhea, nausea, abdominal pain, ulcers, hepatobiliary abnormalities. We certainly know the cardiovascular issues, including chest pain and MI, and we'll hear more about it today. There are ocular manifestations. There have been people in post-recovery phase who have even lost vision due to a retinal artery thrombosis. There are myriad of cutaneous observations, including hives, urticaria, vesicles, and variety of mucocutaneous lesions that may be seen. With all of these, the SARS-CoV-2 has been detected in saliva, respiratory, blood, urine, and stool samples. And some of these are highly infectious. That's the saliva and the respiratory. The urine and stool samples haven't convincingly been shown to cause transmission of the virus, but we do believe that it may have a role to play. When we talk about the investigations in COVID-19, the RT-PCR nasopharyngeal swab still happens to be the go-to test and the one that's most believed, though it does have a sensitivity of 68 to 70%. And sometimes requires multiple tests. The SARS-CoV-2 antigen testing is the other option that is present. We certainly have even rapid antigen tests right now, but they may have a far lower sensitivity, somewhere down even to 50 or 60% range. Clearly, the CBC, CRP, LDH, serum ferritin, chest X-ray, HRCT, all have a very important role, which we'll hear about more. There's obviously the antibody testing, which is more important for serosurveillance and also as a second line testing if the suspicion is very high, but the swabs are negative, and in follow-up. And then obviously for those having the right clinical presentation, D-dimers, troponin levels, and IL-6, which we will also hear about more. The Central Drug Standard Control Organization has approved the following medications for COVID-19. In the antivirals, we have favipiravir and remdesivir. And in the anti-inflammatories, we have dexamethasone, tocilizumab, and itolizumab. Clearly, besides dexamethasone, other steroids are also used. Supportive therapy with anticoagulants, good diabetes control for those who have sugar abnormalities, and then the chronic disease management and complications, which is what we're going to largely speak about today. That's kind of a very rapid run through. When we look at the complications, there have been publications now from several parts of the world which have said that up to 87% patients who have recovered from COVID-19, afebrile, negative RT-PCR, no real evidence of viral shedding, may continue to have respiratory problems or other problems, which we'll talk about, for up to months after the disease. And during the disease, clearly pulmonary complications, bacterial infections, acute liver injury, acute cardiac injury, acute kidney injury, septic shock, DIC, blood clots causing micro and macro thrombi, multisystem inflammatory syndrome, as is seen in children, like the Kawasaki disease presentation with other viruses, chronic fatigue, rhabdomyolysis, encephalitis, prolonged anosmia, depression, anxiety. The list just goes on of what SARS-CoV-2 is doing to the humans, even after they have recovered, because we know 95% patients will eventually recover. We know that from studies, a simple thing like a pain that lingers, brain fog, shortness of breath, arrhythmias, hypertension, chest pain, insomnia, fatigue, vertigo, the list just goes on and on of what this disease can do. And hence it is so important for us to have this webinar to discuss how to pick it up soon, how to investigate it, how to treat it right, and how to give our patients the best chance so that they do not progress and do not go on to have prolonged symptoms later on. The COVID-19 vaccine candidates in the phase 3 trials, we are all very eagerly looking forward to this, but this is still something that is possibly in our 4, 6, 8-month distant future. We'll keep our fingers crossed till we get there. Remember, keep your immunity boosted, fresh air, sunlight, healthy diet, exercise, restful sleep. yoga, pranayama, supplements under medical guidance, keeping a positive attitude and mindset, and meditation. I always put this in every presentation I do because we as doctors are at the front line and at the highest risk of getting this disease. And if we have a strong, healthy, balanced immune system, we will stay protected. With that, I shall conclude my initial introduction of the topic and get going with the meat of the matter, which is our discussion for today with our esteemed panelists about this disease and what we can do about it. And for that, I shall begin with the first case. We have a 62-year-old male with diabetes and hypertension who has had this disease since about 5-6 years. He's on losartan, he's on metformin. He was admitted with a fever of 100 degrees, cough, shortness of breath. Blood pressure is normal, oxygen saturations are 88 on room air, and his laboratory parameters do indicate that he's COVID-19 positive. He's got an elevated CRP, he's got a low absolute lymphocyte count with a reversed neutrophil lymphocyte ratio. His D-dimer is high, his LDH is high, his creatinine is slightly elevated with a low GFR, and he's got bilateral interstitial shadows. With this, I would like to take the first question to Dr. Dhruv. Dr. Dhruv, in a situation like this, what kind of further investigations would you like to do for this patient? Please, Dr. Dhruv.
Thank you, Dr. Sitesh. First of all, we have to remember, and that is the message that I always give to all the people who are listening to this. You have to remember the day of onset of symptoms. Everything in COVID is counted from the day of onset of symptoms. So first of all, confirm the day of onset of symptoms rather than COVID positivity, number one. Then decide whether this patient is having mild, moderate or severe infection. That is very easy to do with the respiratory rate and SpO2. Here one can see that the age is more than 60. Comorbidity is hypertension and diabetes. The SpO2 is 88 at room temperature and D-dimer is high. So this is a very classical moderate case. How do we proceed for investigations first? Which investigation shall we do in this case? So first of all, HRCT before, at the time of admission, if we are fortunate enough to have the facilities of HRCT. So at the time of admission, we get it done and then admit the patient as a baseline HRCT, because as we'll see today throughout our talk, that most of at least pulmonary complication, especially pulmonary fibrosis, depends upon the severity of disease and the CT presentation at the baseline. So HRCT, if it is possible, it is not possible, then the patient may be admitted. If we are going to give antiviral, which we are certainly going to give, then two important investigations, uric acid and liver function test. That would be SGPT and SCOT, because they are going to determine which antivirals or whether we can give antivirals to this patient or not. ECG is a must, because most of the patients might have taken azithromycin or they might have taken HCQS. So we need to confirm the QT interval, because favipiravir, if we want to give, you have to confirm the QT interval. It has got some drug interaction with HCQS. Serum electrolytes may be sent. Ferritin has not been mentioned, so it can be sent. So these are the basic investigation that requires to be sent. Along with this, because the patient is diabetic, I like to send HbA1c. So these are the basic investigations, depending upon which I decide the further course of management. As far as the management is concerned, if I go ahead with the management, then the answer would be simple. We have to start antivirals as early as possible. If remdesivir is available, this is an ideal case scenario for remdesivir. SpO2 has gone down, number one. Number two, age is high. Comorbidities are present. D-dimer is going up. Inflammatory markers are high. NL ratio, that is neutrophil to lymphocyte ratio, is more than 1.73. So all possible risk factors are there. I would like to go with the best antiviral drug that is available. But if the best antiviral drug is not available, which is a sin in many states at present, in that case, one can start favipiravir in this case with, as we know, 1800 milligram twice a day on day one, and then 800 milligram twice a day on day two onwards, provided SGPT and SGOT are less than 5 times normal and uric acid is normal without any history of gout. If remdesivir is available, I would prefer the drug to start with 200 milligram loading dose intravenously on day 1 and then for next 4 days 100 milligram IV. Back to Sitesh.
Great. Thank you very much for that very detailed and very organized answer, Dr. Dhruv. I would like to ask the next question to Dr. Jatin Kothari. Dr. Jatin, in this case, we saw that the patient's EGFR is 40 and their serum creatinine is 1.8. So what kind of precautions and what kind of care do we need to take in this situation? And where is the role of what can we do to maintain the kidney function or avoid it from getting worse? And are any of the drugs that were mentioned in the initial management, do we need to take extra care or caution about them? So your thoughts on this case? If you could just unmute yourself. Great, perfect.
So thank you, Sitesh, and it's actually an honor to be a part of this esteemed panel. To take your questions head on, question 1 was whether we are dealing with somebody who's got a GFR which is 40. First thing that you have to assume in some situations where you don't have a baseline creatinine is that you would presume that the patient either has a pre-existing CKD because he's got risk factors like diabetes and hypertension, and that's very important to assess. So sometimes you have to go back to his previous charts and try and see if there was a creatinine in the baseline done before the admission. If that is not available, then you would presume that this patient has AKI, where the estimation of GFR itself is a big problem. You can't use the formulas for estimation of GFR in somebody who's got AKI. The dictum is that you can use the formulas only to estimate GFR when you have a relatively stable creatinine in an individual patient. So that's something that we need to keep it in mind. The presentations really are different in patients who have AKI with COVID versus somebody who's got CKD with COVID. And we will go to that details when we discuss the case further. To answer your question about use of antivirals and various drugs, what implications it has in terms of the GFR as baseline. Yes, the studies have included patients with CKD, but the moment you have somebody with a GFR of less than 30, all the trials so far of all the medications have excluded people who have a GFR less than 30. So to answer your question in a specific one sentence, yes, there is no data to look at use of these drugs when the GFR is below 30. Despite not having data, we are faced with these patients on a daily basis, and we have accumulated some experience over the last few months of use of the various categories of drugs. I agree with Dr. Dhruv that remdesivir, if available, is probably the drug of choice, even with a person who's got compromised GFR in this kind of a scenario, what the case you presented. We have little experience of use of favipiravir, especially in CKD population. My understanding is that favipiravir would be equivalent or probably more useful in patients who have mild symptoms. When you're dealing with moderate to severe, you're probably looking at remdesivir as the first line treatment. Just one line to add about steroids, and that's a very important part of our armamentarium in terms of treating these critically ill patients with comorbid conditions. Steroids have to be used in patients who are hypoxic. So for any reason, if they are hypoxia and they are requiring oxygen, or if they are requiring mechanical ventilation in the ICUs, steroids almost always will be used. And the duration of steroids is usually a minimum of 10 days. In patients who are critically ill, it has been used even up to a month. With the steroids, we obviously have to be careful about sugars, and I'm sure that Dr. Dhruv is probably as involved as a diabetologist as compared to the internal medicine physician to manage the sugars, because dexamethasone really causes the sugars to really go up and down, especially in people who have pre-existing CKD. So back to you, Sitesh, about these two questions.
Thank you. Thank you. Dr. Dhruv, I'll come back to you and ask you, since the mention of steroids has been made, what is the optimal dosing that should be considered in a patient like this? What dosage would be used typically?
I'll just add one sentence, or rather, we'll ask Dr. Jatin, because we are at a luxury of having HRCT for every of our patients. So what we do in diabetic patients, even before we get creatinine, we ask our radiologist to just have a screening of abdomen for renal size simultaneously without charging. the patient. So that rules out at least CKD, or it confirms the CKD at least with the help of renal size. So that is exactly the luxury. I presume it may not be available to everybody. As far as the steroids are concerned, our protocol is very simple. We generally do not start steroids before 4th day of symptom onset, not the admission. Here the symptom onset are before 4 days, so we would like to start steroids. But again, we generally do not start steroids before giving first dose of antiviral. So only under the cover of antiviral, we start steroids. So we give remdesivir first, and then followed by, we use methylprednisolone, although the WHO has suggested dexamethasone just because it was easily available in UK where the trial results were available. But for India, both the drugs belong to the same cost range. So we use methylprednisolone in the range of 0.5 to 0.8 milligram per kg body weight per day. So generally 40 to 80 milligram, 40 milligram intravenously twice a day. First dose is given 1 hour after remdesivir. Our indication for steroids is very clear. Unresponsive fever on day 5, when we are very sure that there is no secondary infection, number 1, and number 2, with hypoxia under cover of remdesivir or favipiravir. So these are 2 indications. We generally start with 0.5 to 0.8 milligram, give it for 3 days, and then look for the clinical improvement. Here again, once again, I would like to draw the attention of everybody that as long as COVID-19 is concerned, I think despite so many investigations are available, most of the trials have shown or relied upon clinical improvement more than the investigations themselves. So it is clinical improvement which would judge the further course of treatment. The rest of the few points that I would like to add would be obviously adding oxygen to this patient. The awake proning would be very useful in this case. LMWH, our cardiologist, is certainly going to talk about it later on. Antibiotic cover if required. And because we have started with steroid, we generally ask our staff to go for 5 simple sugar, fasting, pre-lunch, post-prandial, pre-dinner, and post-dinner if possible. If it is not possible, at least 3 samples of sugar. Generally, steroids cause rise in postprandial sugar, and therefore basal insulin is not very useful here. In most of the cases, it is bolus insulin or a very short-acting insulin that is helpful. Many times people use ripaglinamide. Kindly remember, ripaglinamide has a drug interaction with favipiravir, so must be avoided. Similarly, tenaligliptin, which is generally going on, should be stopped because it causes QT prolongation and causes drug interaction with favipiravir and with remdesivir. And same way, SGLT2 inhibitors, if they are going on, we stop it on day 1. So generally, metformin in this case is going on, will continue as long as the appetite is good, and would keep an eye on postprandial sugar because those will be the figures that would go high, and we might have to add preprandial short-acting insulin. Over to Siddhant.
Thank you very much, Dr. Dhruv, once again. Dr. Ameya, I would like to ask you in this situation, if this patient were to start having some chest pains and the doctors would do a troponin level and the level came high, in that kind of a scenario, what would you want to do additionally for this patient, and what kind of investigations and monitoring would you like to do for this patient if there were some cardiac manifestations that showed up in the course of their hospital stay?
Right. So in COVID, as we see in our clinical practice, and also what has been known currently because of publications, that 20% of these patients will have a cardiac marker which is called as troponin I, which is positive. Now this is released only when there is myocardial injury in the myocardium. So if there's a myocardial injury, that time the troponin I levels will tend to rise in your blood. Now, as per the studies, 20% of COVID patients have been found to have this increased troponin levels. Now, most of these patients are basically moderate to severe COVID infection, not so much in mild infection. So you may not see that in a mild patient, but you will definitely see it in patients where the inflammatory markers are risen. So first of all, I think if there is a chest pain, I would definitely rule out whether this fellow is also having a comorbid cardiac condition, especially ischemic heart disease. and especially considering the risk profile of diabetes, hypertension, old age, elderly, then definitely we would like to do, the first thing is the ECG, see whether you have any STT changes. So if you have STT changes which are suggestive of ischemia, then the second step would be to keep a watch on both ECG and the cardiac markers. So recurrent, say every day at least once, we would like to repeat a ECG to see whether there is an ST elevation. We also know that COVID per se can cause an arterial thrombosis risk of 2 to 6%. So this can cause an acute myocardial infarction. We have had presentations of acute ST elevation MI as presenting as ST elevation MI because of arterial thrombosis. And most of these patients will have some regional wall motion abnormalities or a rejection in the heart pumping on a 2D echo. So the two things which I would definitely advise is an ECG every day to see whether there are STT changes which are suggestive of ischemia. Number two is a 2D echo to see whether you have a regional wall motion abnormalities. Because when you have ischemia, it's a particular artery which is involved. And that's why your regional wall is limited to a particular area or a territory. You don't see the whole global LV ejection fraction going down. So if you see the whole global LV ejection fraction going down, our diagnosis will change to a non-coronary etiology, for example, myocarditis. So again, myocarditis, we know it's not very common, but in the inflammatory state, we have seen that it can cause a depressed LV dysfunction. And there is also something called as pericarditis or myopericarditis, which is also quite common in vital illnesses. These are the two things. There is something called as a Takotsubo, which is called stress-induced cardiomyopathy, where the heart suddenly balloons out because of stress. So because of this illness, you will have a sympathetic overdrive, which can cause a lot of activation of the sympathetic hormones and the enzymes, causing acute dilatation of the left ventricle. So these are the 3-4 things which we would normally like to observe, especially if you have chest pain. Now, the thing to remember is majority of the elderly will have a coronary artery disease. So a lot of patients will have comorbidities which are coronary artery disease. They must have undergone a bypass before or angioplasty before. So the main thing to remember is that do not stop your ACE inhibitors, because there was a lot of, hue and cry, controversy, whether the ACE inhibitors can harm the patient, whether it should be stopped. Now there is conclusive evidence saying that you need not stop these drugs. So the main thing is that the medications, especially the ACE inhibitors, ARB, should not be stopped.
It's 8 o'clock.
The statins, which are also important for stabilization of the plaque, should not be stopped, and the antiplatelets. So most of the chronic stable coronary artery disease patients will be on ACE inhibitor, will be on a statin and antiplatelet. I think the important thing to remember is, especially if a chronic coronary artery disease, these 3 things should not be stopped. And observe them so that if you have a cardiac thing like chest pain, breathlessness, heart failure, cardiogenic shock, then probably we'll have to intervene either in the form of some intervention like angioplasty or hemodynamic support. So back to Sitesh.
What would be the role for anticoagulants and low molecular weight heparin in such cases? I open it up to all the panel in a situation like this. Anyone who would like to chime in and say, how important is that? Should that be done as quickly and routinely as we talk about using steroids? Because we know that microcoagulopathy can happen anytime. So in a patient who's having respiratory symptoms, who's having low SATs, who's having chest pain, what is the role? And his kidney function is a little down. What is the role of anticoagulants in this? Dr. Ameya, you first, then Dr. Jatin, if you want to add in, please, and anyone else.
Because now off late we have a lot of publications with an increased incidence of thrombosis. Now thrombosis can both be arterial and venous. Arterial thrombosis found in the range of 2 to 6%, while venous thrombosis found in the range of 20 to 25%. Especially when you have the inflammatory phase, when the inflammatory phase is also associated with clotting abnormalities and increased thrombosis. That is the time when these patients are more prone for pro-thrombotic complications. The important thing to remember is, compared to DIC, where you have only a D dimer which is high, in this condition, you will have a D dimer and a fibrinogen, which is also high. So that is one of the differentiating points. So if you have a D dimer, which is very high, now guidelines recommend that if you have more than twice or thrice the normal value of your D dimer, then definitely these patients should be on anticoagulation, at least for a prophylactic, for a DVT prophylactic point of view. So normally recommendation is to give a 0.4 ml once a day. But if your D dimer is strongly positive, that's more than twice, and if your inflammatory markers are positive, then you will have to treat them as a DVT case or a suspected DVT case. So there your dose will be therapeutic. That is normally if we prefer a low molecular weight heparin, which is Clexane, if your GFR is okay, then 0.6 ml 12 RMA. That is the recommended dose. Long term also, if your D-dimer during discharge tends to remain high, there has been reports where patients have come back with pulmonary embolism, deep vein thrombosis, arterial embolism, and that's why the recommendation, at least from the Thrombotic Society, that's the hematology group of the world, is that you should continue the anticoagulation at least for a month to 6 weeks. So we tend to follow, if you have a D-dimer which is high during discharge, especially if it's twice normal, and you have a low bleeding risk, because you have to balance the bleeding risk with the thrombosis risk. So if you have a low bleeding risk, then they should be put on anticoagulation. So at discharge time, we normally prefer a NOAC as a DVT prophylaxis, the doses which are recommended for DVT prophylaxis. So that is the recommendation which we normally give. And after a month, probably they can repeat the D-dimer and see if it is returned to baseline. If it's returned to baseline, then we don't recommend to continue it further.
Great. I think those are very clear guidelines. Dr. Jatin, anything you would like to add about the use of anticoagulants in a patient like this?
I agree with Ameya that basically you are going to start low molecular weight quite early in the phase, especially when you have a presentation which is a moderate to severe. No doubt about that. But the dose is more towards therapeutic doses rather than prophylaxis, because underdosing is a big problem. And if you underdose the patient with a life-threatening complication like thrombosis, you will be landing up with much more morbidity later on. So err on the side of giving a therapeutic dose rather than prophylactic. As far as renal function and the dose of LMWH and the choice of LMWH, for whatever reasons, the deltaparin has been most studied in patients who have compromised GFR. So we are more comfortable using deltaparin, which is Fragmin, in our patients who have a compromised GFR. The dosing could be 2,500 to 5,000 units. If you feel that the patient has got a severe illness, definitely start with 5,000 units once a day. And if it's a moderate sized patient with a weight of below 50 kilos, we are okay with 2,500 dose also. So preferential use of dalteparin over other LMWHs, but we have also used a lot of enoxaparin in the dose adjustment that Ameya mentioned. We don't go with the high dose when you are looking at enoxaparin use in patients who have got CKD. So that's my only comment. You almost universal use, at least for a period of 2 weeks. We use D-dimer as a parameter to even stop the low molecular weight heparin. So when the D-dimer comes back to normal, then you are relatively certain that you're not going to see that exaggerated risk of thrombosis, where it might be safe to stop the LMWH. So you don't want to go on and on with the low molecular weight heparin, and probably use D-dimer as a modality to try and decide on when to stop. Back to you, Sitesh.
Great, thank you. Dr. Gadani, you've been very patient and hearing all of us. So a question for you. This patient also interestingly had anosmia on coming in, which they reported became more problematic while they were in there. So is this a common condition in your view, and are there some long-term implications of it? And what kind of things would you want to also be wary about or observe about in such cases that have very significant anosmia, almost total loss of smell and taste in such cases? Your thoughts and comments.
Yes, Dr. Sitesh. Anosmia has been very commonly described as an initial manifestation of the COVID-19. The thing that you should keep in mind while anosmia because of the other virus illnesses and that of the COVID-19 is that the COVID-19 anosmia is usually not associated with the rhinitis or nasal stuffiness. So if you have a patient who came with the anosmia or dyspepsia in your OPD and he doesn't have a history of rhinitis or nasal condition, you must suspect this as an initial manifestation of the COVID-19 patient. Now, this anosmia can occur because of the direct olfactory bulb involvement of the COVID-19, or it may also occur because of the microvasculature involvement of the olfactory vasculature. So, and the various studies have seen that the biopsy has shown the axonal involvement. MRI are also shown to have some enhancement of the olfactory bulb. The thing is that the studies have shown that the anosmia patient, about 44% of the patient usually recovers after about 8 to 9 days of recovering of that primary symptoms. So in most of the patient, in about 60% patients, anosmia may be a disabling problem for a very long time. Back to you, Dr. Sitesh.
Yeah. And like you mentioned that because this seems like there may be some axonal involvement and there's question whether the virus gets access through the cribriform plate, is there also a risk of encephalitis in these cases, and do those kind of cases also sometimes, like if this patient suddenly had a change in consciousness and other issues come up while they were hospitalized, would this be a situation in which we can expect, because the virus clearly has a direct access into the brain from the olfactory pathway? It seems to do a very, very common job in affecting people in their sense of smell. So your thoughts on that?
Yeah, absolutely. The COVID encephalitis has been described in various literatures. Various cases has been presented in which the patient has signs and symptoms of encephalitis, and the COVID virus has been isolated from the CSF. Now, the entry into the brain may be either directly through the olfactory bulb, or it may be because of the hematogenous state. The thing is that not all the patient who have COVID-19 patient who have signs and symptoms of encephalopathy has a COVID encephalitis. You must rule out the other treatable causes like that of the non-convulsive status epilepticus. Some stroke may present with the encephalopathy-like features. Patient may having some ATM-like illnesses, some brainstem encephalitis, the cortical venous thrombosis, ADEM, or meningitis. All these have a presentation, including some metabolic abnormality, some drugs, all can contribute to encephalopathy in this patient. So before stamping any case with the altered sensorium in COVID-19 patient, you must rule out the other causes of the encephalopathy. Then you should search for the evidence of COVID infection into the brain by doing the CSF examination, and then you can definitely stamp as one of the association or a probable cause of encephalopathy as a COVID encephalitis.
Great. Thank you very much. Dr. Dhruv, back to you. In this very patient, after they had they were well managed by very good specialists such as you, and about 10-12 days into their hospital admission, the patient recovered and has gone home. While they are going home, are there certain investigations that as a pulmonary specialist, or given that they had lung involvement and this patient on their HRCT had ground glass opacities that were detected, and they had a score of about 12 out of 25 or 13 out of 25, somewhere in that range. What kind of counseling should a patient be done about post-COVID complications, respiratory complications? And what kind of investigations, if any, should be done before the patient leaves the hospital? And when would you call them back while you're discharging them on the anticoagulant, possibly on a steroid if they're still having some issues? And what else would you like to do in that situation in terms of their lungs to keep them safe?
So, generally, the pulmonary fibrosis is seen with 5 important risk factors: age, the length of stay in hospital, especially in ICU, the severity of disease, as you very rightly mentioned, the CT score, that is the radiological picture at the baseline or at the end of the first week, and history of smoking. So if all these factors are there, even chronic alcoholism, so if all these factors are there, or at least 4 out of these 6 factors are there, we generally suggest, especially those patients who are discharged from ICU or those patients who are discharged after a prolonged stay, where by prolonged stay, our hospital means more than 14 days. There we go for HRCT before discharge, 1 day before discharge, so that at the end of 4 weeks, we can compare that HRCT, because generally the pulmonary fibrosis would start after the 8th week, only then we can define it. So only in these cases we'll go for HRCT at the time of discharge. The patient would be strictly instructed to measure the blood sugar as he is diabetic. He would be instructed to measure oxygen saturation very routinely. Preferably, he should be asked to go on walking, starting from 3 minutes a day, then 4 minutes. We ask them to increase 1 minute every day, and at the end of walking, we ask them to measure SpO2, and if there is fall of 10% from the baseline, so initially is 98, And if it falls by 3, that is 95, at the end of 6 minutes or 7 minutes, whatever he walks, then we ask them to come back after 1 week. If the patient has fever after going back home, we ask them to come back after 1 week. If the patient has chest pain, we ask them to come back after 1 week. Those patients who are on DVT prophylaxis, that is the anticoagulants, we ask them obviously to look for the bleeding from any site and avoid NSAIDs very strictly. We do call them at the end of 1 week in all these cases. Otherwise, we go for video conferencing at the end of 1 week and call them after 2 weeks. We go for only pulmonary function test and if required to do echo and D-dimer, as very rightly pointed out by our cardiologist and nephrologist friend, at the end of 2 weeks when we can shift over the anticoagulation profile or medication. And then we suggest them to go for deep breathing exercise, meditation, especially we go for a very simple exercise. We ask them to blow the balloons 10, 15, 30 times a day and have an objective measure how many balloons they can blow. Last week he could blow 10 balloons and now if he can blow only 8 balloons, that means he is probably heading for some sort of pulmonary insufficiency. In all those high-risk cases, that is age, smoking, severity, radiological picture where you had 50% or more of lung involvement, we go for HRCT at the end of 4 weeks again for deciding whether the pulmonary involvement is improving or whether it is leading for some sort of bronchial traction or fibrosis that would be visible there. Back to you.
And in case there is evidence for bronchial pulmonary fibrosis that is seen at the end of, let's say, 4 weeks, they're still having persistent lesions. Now that there are more and more cases coming of this, what is your opinion about the use of pirfenidone in such cases? Do you think that there's any role for that?
All the trials across the world have shown that pirfenidone should not be used before 8 weeks because most of the lesions, they regress on their own at the end of 8 or 12 weeks. This was the experience with SARS virus or MERS virus also. So we should not start this drug, not only because it is expensive, but also because most of the patients, they do heal and the healing takes generally 8 weeks. So we generally do not start pirfenidone before 8 or 12 weeks. If at the end of 8 weeks, there are radiological features of non-healing or definite fibrosis, then we give option to the patient that these are the options which you can start. But steroids are always preferable in these cases for up to 8 or 12 weeks and only at the end of 3 months after discharge, unless there are a strong indication of definite pulmonary fibrosis or loss of volume or the diaphragm going very high, even on a chest X-ray, or the dyspnea is worsening despite the steroids going on with radiological worsening picture. Otherwise, we generally don't suggest pirfenidone before 12 weeks. Whenever we start it, we explain the expenses and the side effects to the patient, and then we start at the doses of 400 milligram intervally. Remember, this is only a 9-month-old child, COVID-19, and very few experiences are there with pirfenidone in these cases. Whatever experiences are there are more from the IPF rather than post-COVID pulmonary fibrosis. So it is safer to wait a little bit longer depending upon the previous experiences with the previous viruses and not to start pirfenidone before 12 weeks. Over to you.
Thank you. Dr. Ameya, in terms of the cardiac risk that patients face in COVID-19, are there any particular comorbidities? We've mentioned the hypertension, the diabetes, some of the common ones that we know, but are there any specific comorbidities or anything additionally that when you are taking a history of a patient that walks in and you're being asked to consult or taking care of, that you specifically focus on? And what are the typical issues that a patient with COVID-19 can face in relation to their heart?
Right. So coming to comorbidities, as we rightly discussed earlier, hypertension is the commonest comorbidities in the studies which have been done in China and US. And even at Hinduja, I think one of our consultants had a small presentation in which she said that hypertension was the commonest comorbidities. The second is coronary artery disease. Now, coronary artery disease is very prevalent in the elderly population, And that's why if you have a patient who is having a coronary artery disease, especially an acute coronary syndrome, that is either an ST elevation MI or a non-ST elevation MI. So these both conditions will normally present with acute chest pain with ECG changes. So if you have a patient who has come with acute chest pain with ECG changes, we will activate what is called as the acute chest pain protocol. Now, as per that protocol, normally we need to see whether there's acute myocardial infarction taking place, and we need to open up the artery, which is thrombosed. Now, this is either done by thrombosis or a thrombolytic agent, that's a medication, or by angioplasty. Till the COVID era, we were almost doing angioplasty for all these patients. Now, because of COVID, because of the risk to the personnel who are operating and the cath lab personnel, the angioplasty numbers have definitely come down. So here the goal is to at least revascularize them with a pharmacological agent. So if you have a patient who has come with chest pain, which is acute, and is showing you changes of ST elevation MI, that is an acute myocardial infarction, the first goal would be to thrombolyze the patient. So we have thrombolytic agents which we normally give intravenously, and then we monitor those patients. The second is I would be concerned if the patient is acutely breathless. So if you have acute breathlessness with ECG changes, of course there can be ARDS, which is definitely there in the picture, but then these patients may also be in acute left ventricular failure. Now, there are multiple studies where they have found that patients, especially the critically ill patients, will have cardiac dysfunction. So when you have cardiac dysfunction, these patients will definitely have a reduced cardiac output and pulmonary edema. So these patients, especially when they're critical, I think they will need to be on inotropes, they will need to be on diuretics, they will also be needed to be given a hemodynamic support. Now, hemodynamic support entails in, say, insertion of devices like intra-aortic balloon pump or starting of ECMO. So this is definitely for critically ill patients. So if you have a chest pain, acute chest pain, then the acute myocardial activation protocol will be taking place so that you revascularize the patient and thrombolyze the patient and open up the artery and take the patient for angioplasty once he's COVID negative. Now, in the last 1 month or so, I think some of the tertiary hospitals in Bombay are also doing a primary angioplasty in COVID positive patients with the use of PPEs. So they are taking that risk head on and doing the angioplasty by using good use of PPEs. So that is an option, again, patients with acute myocardial infarction. You have acute LVF, that is heart failure. Now, this can be a chronic patient who has already had a reduced LV function before, or it can be a fresh event which is because of myocarditis, or as I said, stress cardiomyopathy, which is Takotsubo, or it could be just a viral infection of the myocardium, or inflammatory myocardium, or it could be a septic shock because these patients are in cytokine storm and septic shock. This can also cause a secondary dysfunction of the heart. So I think it's a multidisciplinary approach, especially when you have a patient with acute heart failure, because this patient will also have ARDS-like picture. So in consultation with the pulmonologist, they will need to be intubated. The ventilatory settings will need to be adjusted so that you can give some amount of PEEP, because here we don't use in ARDS, we don't use large lung volumes, or tidal volumes are normally less. But for the patient of pulmonary edema, we would want to give them some amount of PEEP. So again, that will be a picture. Third is the use of diuretics. So diuretics will definitely come into the picture to see the urine output and the blood pressure and the inotropes. Use of long QT drugs. Now we have seen that in a lot of patients, because of an initial fear, there was a lot of ingestion of azathioprine and hydroxychloroquine. Now that both can prolong the QT. Antiviral drugs like leponavir, ritonavir can also prolong the QT. And if you have electrolyte imbalance like low potassium, low magnesium, the QT is going to be much worse. And add to that, if he's taking antidepressants or a prokinetic or any antiarrhythmic drug, the QT is going to be worse. So there has been an increased incidence of patients presenting with polymorphic VT, which is called as torsades. And this is basically drug induced. So the first thing would be to go through the drug chart, see what medication these patients are taking, and see whether any of these medications can prolong the QT. And the recommendation is that if your QT interval is more than 500 milliseconds, the corrected QTC, which we call as QTC, corrected QTC, if it is more than 500 milliseconds, you need to stop all these long QT prolonging drugs. So that is the recommendation. Long term, so the acute management will be a multidisciplinary approach by the cardiologist, by the infectious disease specialist, and the intensivist. The long term is that once the patients recover, we know that especially patients with LV dysfunction, whose myocardium is suppressed, the ejection fraction is low, there are two drugs which need to be given. First one is an ACE inhibitor or ARB. So that is number one. And the second one is a beta blocker. So these we consider as life-saving drugs when it comes to LV dysfunction. So this definitely will need to be seen that if the patient is able to tolerate them, blood pressure is good, heart rate is good, the patient is not in heart failure, then we will try to initiate an ACE inhibitor at least at the time of discharge, so that they go home with the ACE inhibitor. And probably in the first visit, once they are stabilized and moving around, we may add a beta blocker. So this is one. Another thing which we see is commonly we have seen COVID patients have a 40% incidence of arrhythmias. Now, arrhythmias is heartbeat disorders. So you can have atrial fibrillation where the heart goes irregular. You can have AV block. You can have a torsade as we just explained. You can also have SVTs or irregular arrhythmias like SVT or ventricular tachycardia. So again, here the goal is to see what is the etiology, whether it's a new onset arrhythmia which is due to COVID or it is a pre-existing condition, and treat them accordingly. Yeah, back to you.
All right. Great. I think that's a very detailed rundown on all the things that we can look at in these cases and what needs to be monitored and done. Dr. Jatin, I would like to come to you and ask you if this patient of ours who was admitted happened to suddenly get worse on day 6 or 7 of their admission. When would you be considering the use of tocilizumab in a patient like this? And if it was not available, are there other options of what could be used? So your thoughts and comments on that.
So cytokine storm, as Dr. Dhruv initially mentioned in his first case scenario, is a possibility in patients who are critically ill, who have multi-system involvement. And that's where probably the role of tocilizumab is well established. In patients who have moderate to severe illness without multi-organ involvement, the role of tocilizumab is still unclear. There is no data, again, talking about compromised GFR, there is no clear-cut data of use of tocilizumab. However, all the recommendations are recommending that if you were going to use that for primarily cytokine storm, then you don't need to bother about renal dose adjustment. Most of the drugs, the antiviral drugs and the anti-cytokine drugs do not require any dose adjustment. So you would give the standard dose. Obviously, monitoring becomes more important in patients who have compromised GFR. If anybody has a further worsening of creatinine, you would probably want to stop the dose, and especially if you think it's drug-induced. Of course, if the liver enzymes go up to 5 times of the baseline, then you would be forced to stop the antivirals, including remdesivir. So that would be a problem. Otherwise, tocilizumab has been used in these clinical scenarios with reasonable optimal results and in the right patient. So I would go ahead and support the intensivist in terms of use of tocilizumab. Early initiation of dialysis, what we consider in patients who have AKI of non-COVID reasons, is a definite yes, but in COVID scenarios, we are trying to delay dialysis as much as possible because dialysis does not seem to have changed the outcomes of people who have got severe AKI, especially grade 3, who require dialysis. So somehow dialysis seems to be not that much favored in the early phase. If you are able to manage with diuretics, as Ameya mentioned, and maintain patients' urine output, if the ventilatory settings is something that you can manage with just ultrafiltration, that is reasonably better rather than attempting to do dialysis, because early dialysis for sure doesn't seem to be contributing to improving outcomes. So dialysis seems to be a backup treatment only if required, if other things are failing and the outcomes of dialysis are not very good. So use of all these drugs are definitely initiated and required in patients who have severe illnesses, especially of the multi-system variant. Back to you, Sitesh.
Great, thank you. Dr. Gadani, a question for you now. In a patient who's having some neurological manifestations in the midst of their admission, maybe they were recovering and then, or in this case, let's say they got intubated for some reason and were on, some muscle relaxants for a few days. And following that, when they were better, their requirement of ventilatory support was not there. They should be breathing and coming out normally, but they are not coming off the ventilator as easily, or they come off and they seem to be not themselves. So in such situations, what are the kind of investigations or further workup as a neurologist that you would want to do or think of doing in such cases?
Yes, the difficulty in breathing is a common problem in the critical ill patient, just like as in COVID-19 critically severely ill patients. Now, the patients who had improved their lung function, the cardiac function is improved. Despite of this, if the patient is having in a normal state of consciousness and he is not able to be weaned from the ventilator, then you must consider neuromuscular weakness as one of the cause of the this difficulty in weaning. Now we know that COVID can affect the central nervous system as well as it has some implication also on the peripheral nervous system. GBS has been described in the patient with the COVID-19 infection. However, the GBS tend to occur as a para-infection complication. So it occurs usually between the 5 to 10 days of starting the symptoms. While the critical illness neuromyopathy that we commonly see as one of the main problem in difficulty meeting the patients tends to occur in the later part. Also, myositis has been described in the patient with the COVID-19 patients. You must see the CPK total, you must do the EMG and CV. And some of the patients who are difficult to wean from the ventilator are diagnosed as a myasthenia gravis. Like myasthenia has been unmasked because of this COVID-19 infection, and treating this myasthenia with either plasmapheresis or IVIG may help these patients in winning the ventilator. So as an investigation or as a workup in these patients, I would like to do the CPK total, EMG and CV study as well as the RNAs, as well as the acetylcholine receptor antibody in the patients who are difficult to win from the ventilator. Back to you, Dr. Sitesh.
Great. I think that's a very, very succinct and clear indication and another example of how much this virus can do or leave a person with at the end of its journey or in the process of its journey, and makes it so important to have a very close, astute watch on patients and see where things could be going wrong, and be open-minded to realize that there may be more than one reason why they may be having a certain problem, and going down a very a carefully designed algorithm or pathway in order to work them up so that you can get to the right cause. Clearly, this virus has kept all of us on our toes like it has the whole world. From all of this, what I would like to now ask as an open-ended question before we start taking some questions from the audiences is in terms of these cases that are being seen, because I know that we do have family physicians, general practitioners also watching us. For whoever of you all have had experience with using or seeing some patients outpatient or managing them or guiding care, what is the role of, what can be done so that a patient in each of your specialties, so that the patient doesn't go downhill, in other words? Okay, are there any anticipatory or preventive things that could be done? We can start with you, Dr. Dhruv, since you're on the line. Do you think that in some of these cases where people are getting worse, they are coming to the medical care facilities late? They're not starting antivirals like favipiravir that can be done outpatient sooner. Do you think that they're waiting too long to really get very breathless and, get too much of complications before they are coming? So what's the kind of message? Because we clearly are seeing a huge rise in cases. Just we are doing 12 lakh tests a day. We are seeing almost 1 lakh new cases every day in this country. Fortunately, most of them are still mild. And fortunately, our case fatality rates are not very high. But in terms of prevention, I just would like to hear all of y'all's opinions in terms of antiviral usage, early antiviral usage, or preventive care that you all would want to give a message to our listeners, our audiences, our physicians.
Fortunately, after month of April, Ahmedabad is one of the places where we do not have that problem. We have got enough hospital beds. Touch wood, it remains. Most of the family physicians have started using antiviral on day one. We have got a luxury of getting the investigation done on the same day of symptom onset, getting the results. Investigations are cheaper, and you will not believe, but in Ahmedabad at present, rapid antigen test is being done on every crossroads by Ahmedabad Municipal Corporation. There are tents which have been established, and at every crossroads, they have put a board that come here, get yourself tested. So most of the things are quite good, but still the message is very clear. Look for the day of symptom onset and start antiviral as fast as possible. When it is OPD basis, favipiravir; when it is indoor, remdesivir. But early, very, very early favipiravir. Maybe suppose if our patient, one of the patient is COVID positive in the family and rest of the patients start developing symptoms, we ask them to start favipiravir while sending the reports only, because we know that most of the time it is going to be COVID only, looking at the history. So favipiravir as early as possible in OPD setting, as early as possible. There is probably no role of favipiravir after 5th or 6th day of symptom onset. So as early as possible in the OPD setting. That is number one. Number two, steroids at least on 5th day of symptom onset if fever persists and you ruled out the secondary infection. Avoid azithromycin, HCQS as long as possible. They have no role, they are completely outdated. At least azithromycin should be now thrown out of our armamentarium. And in those who are having very high risk, start anticoagulation at the earliest. Probably these things, along with lesser use of tocilizumab, has probably saved India as compared to the rest of the Western countries.
Great. I think that's a very clear message and answer. Any of the other panelists who would like to chime in about the early treatment? And, I feel that given all the complications that can occur if the disease goes out of hand, I think all of us would agree that if we do have an agent that can potentially help, such as favipiravir, we certainly need to consider using it. I know that there are still some people who are on the other side of the fence and say that the data is not as strong, or there are some trials that have not shown a very big effect. But in our hands, we have certainly seen that the patients do seem to do well. And the key is, again, I think it's almost like using oseltamivir in flu. If you started in the first 48 to 72 hours, you happen to get the best effect on the viral loads and the viral replication that you may get, and the later you use it, the effect is still there, but not as much. So I think that the message is clear. Anyone else would like to add from personal experience or their thoughts on the idea of starting treatment early so that we can really prevent people from needing our services later on because they are having complications and problems? So any thoughts from anyone? Please.
Just as a nephrologist, just a couple of points.
Yes.
Sorry, Amir, you can go.
No, go ahead, Dr. Kothari, you're on.
Yeah, nephrologist, unfortunately, since we are a very few across the country, we always think about prevention and try and reduce the number of patients coming to us. So we are usually careful in all patients, but specifically related to COVID, yes, look at the hydration status, make sure they don't take any nephrotoxic drugs, especially NSAIDs, because sometimes these fevers of COVID patients take 2 to 3 weeks to resolve. You have to give them a bunch of steroids and other antiviral drugs, etc., till the fever differses. So not fall into the trap of giving them non-steroidals to have the fever controlled, because that's going to really hit you hard in terms of long-term outcomes. Even if a patient has a normal creatinine to begin with and the creatinine is elevated the time you see them, you would assume that it is AKI, and most of the people think that AKI is almost always reversible and kidney function will come back to normal when patients recover. I want to tell the entire audience who's listening to all of us today that one of the biggest risk factors for chronic kidney disease in COVID as well as non-COVID is the episode of AKI itself. There is a certain number of patients who will not recover from this AKI, who will be left with some residual renal dysfunction, who will then become a patient who's got CKD, and then you will have to follow him up for the rest of their lives. So that's something which is a very, very important risk factor that we can prevent in some ways. If you tackle the AKI better, make sure they are well hydrated, make sure they are not using nephrotoxic drugs. If they are using drugs which need to be dose adjusted, thankfully, at least in the COVID, all the drugs that we talked about, they don't require any specific dose adjustment. But if they are on a high dose of ACE inhibitors and ARBs and you're not sure that their intake is not very good, temporarily for a short period of time, you can stop these drugs. And as Amir mentioned, long-term, you're going to put those patients back on the ACE inhibitor if they've got a cardiac issue. But for the temporary phase, make sure that they are not on all these drugs. It make it more likely that they will develop a non-resolving AKI and progress to CKD. So these are the 2 or 3 observations which we want to make and emphasize to the entire community that's listening to us today. Back to you.
That's wonderful, Dr. Kothari. I have actually one follow-up question because we do get asked this sometimes. between the different NSAIDs, because I think this is so important, so important, because it's used like water, literally. People are giving huge doses. I know people in UK are giving 2 grams of paracetamol 3-4 times a day. That's huge. So between the different NSAIDs, any that if had to be used are safer than others in your opinion, or is there any role for any other way of fever management that y'all as kidney specialists would especially wake people up to and say that consider this?
So antipyretics are the way to go, Sitesh. As you mentioned, there is nothing like a safe non-steroidal anti-inflammatory drug. We know the Vioxx stories and the Celebrex stories in the early 2000s. They were proclaimed to be good for the kidneys and they were used wide across, and they found that the nephrotoxicity was much more than the existing NSAIDs. So there is really no NSAID that is going to be safe. Even large doses of paracetamol up to 4 grams a day have been studied and reasonably safe. But yes, you will have to monitor the liver enzymes if you are going to use it for a prolonged period of time, because you don't really want to deal with an acute liver injury because of a drug. So no non-steroidals, preferably use antipyretics, the age-old things like, cold sponges, etc., to try and get the temperature down. Thankfully, at least in the COVID, we are not seeing patients having sort of malignant hypothermia. They're not going up to 104, 105 like malaria and dengue. So thankfully, we are not able to, we are not facing that problem. But otherwise, just antipyretics, plain simple, and explaining to the patient that the fever is going to persist for a longer time. Maybe the steroids will break the fever and eventually cause the patient to become afebrile. So that's just a word of caution. I think Dr. Dhruv has a comment.
Yeah, not a comment, but unfortunately, despite saying all good about Ahmedabad, we are now facing the mosquito-borne diseases like anything. And so there is a very important advice. Generally, most of the family physicians are not looking at platelet count these days, because in COVID, platelet count is not affected. But if your patient starts developing fever again, especially high-grade fever, with little bit fall in platelet count, immediately go for QBC for MP and dengue at present in Ahmedabad, because we are having lots of double or mixed infection, COVID with dengue and COVID with Vivax. So that is to be kept in mind. Platelet count has its own importance.
Just one comment on that, Sitesh. Sorry.
Yes, yes, go ahead.
The other day we were just joking, and I think Amey would have experienced that. We are trying to come up with a terminology called COVAX, which is
you might get called up by the vaccine guys, because they've already taken part of it. So I think this answers one of our first questions from our audiences has been how to tackle a post-COVID patient with high fever spikes, almost all readings above 101. Regarding fever workup, everything is negative. So dengue is negative, malaria test is negative. It might as well be the flu. We are still in potentially flu season. So any thoughts on that? And are you all seeing any such cases? Because I have certainly seen a share of patients who've had fever, as you all rightly said, persisting for up to 2 weeks sometimes in this disease. So any thoughts on that? If the usual targets are negative, what to do in such cases? Yeah, Jatin, I think
just have the oxygen saturation measured. And if they have any element of hypoxia, in the absence of any obvious contraindications for steroids, probably use of steroids early on would help to control the fever better. That's the only comment that I have. Obviously, if they are progressing in terms of a milder case becoming a moderate to severe case, yes, they will be hospitalized. And then, as Dr. Dhruv mentioned, hospitalized patients, we are preferring to use remdesivir. And we've used remdesivir only for a symptom of fever for a lot of our patients. So they don't have any biomarkers, abnormalities. They don't have any renal dysfunction at baseline. Nothing, but just the fever itself and a toxic look of the patient does suggest that remdesivir should be used in these patients to try and prevent them from going on to have multiple more complications.
I think procalcitonin can be sent in these cases, persistent fever, when we try to rule out bacterial infection. And a nephrologist being there, a urine routine micro, which would be a common, UTI would be common with chills. But procalcitonin would be something which I would like to send if fever continues to remain high, despite all said and done.
Very important point, and the point is well taken, because secondary bacterial infections, we very well know, even a simple bacterial pneumonia may come up after such an incident, because the person's immune system is quite drained and tired fighting the virus and all the consequences of it. I'm going to start taking some of our audience questions. What is the cutoff value of blood sugar to start steroids? A very interesting question. Like, is there a blood sugar level above which steroids should not be used, or I kind of know the answer, but anyone who wants to take it, please mention.
I think Dr. Dhruv is the most qualified to treat all our diabetic patients.
There is no need for any such range. You can start because steroids are life-saving drugs here. So at any level of blood sugar, you can start it, even if it is 300, 400, you can start it and start insulin along with it. As I told you, keep an eye on it. However, one important thing that I would like to suggest would be all COVID-related mortality have been associated with 3 blood sugars. Number 1, HbA1c, which suggests your previous control, sugar at the time of admission, which could be stress-induced sugar, and blood sugar maintained across the hospitalization. So everything needs to be kept under control, and the best thing would be to start short-acting insulin, preferably Fiat, before lunch and before dinner, and keep an eye on the blood sugar level. But there is no need to be panicky. Whatever is the blood sugar level, steroids must be started if they are indicated.
Completely agree. The next question, actually, I think Dr. Gadani might be able to take this for us. The doctor writes, one patient became hypomanic just after recovery and discharge from the hospital, was a hypertensive diabetic patient, 50-year-old, a school teacher, no past history or family history of any such problems. What should be the approach to such a patient who becomes hypomanic after a COVID recovery?
Yeah, after the COVID recovery, the encephalopathy features that he had described as a hypomanic can be because of the variety of this. But one of the most important things that you should keep in mind is the inflammatory response, that is the ADM-like illness, and also the metabolic workup. So this patient must undergo an MRI scanning to see any lesions in the brain that is showing some hyperintensity. Also, we have also seen some of the patients with the NMD encephalitis who become psychotic after the recovery from the this COVID-19 infection. So, if the patient develops his psychotic features post recovery from this COVID-19 infection, you must search for the encephalitis and inflammatory response. You must
I think Dr. Gadani is having some problems with his connection. Till we get him back online. Okay, I think he's back online. Dr. Gadani, please continue. We had lost you for a minute. Yeah.
Yeah, so if the patient remains psychotic after the recovery of the COVID-19 infection, you must keep in mind of autoimmune encephalopathy in this kind of patient, and he must undergo MRI, and if needed, CSF exam must be done in this kind of patients.
Great. So MRI, CSF study, and a careful history to evaluate what the progression of the symptoms has been to decide what the potential causes may be in these cases. Great. Next question for Dr. Ameya. A 56-year-old male with open heart surgery in 2011. Should we start injection low molecular weight heparin prophylactic dose from second or third day of appearance of symptoms of COVID? Patient has had fever with normal oxygen saturations. Should we be using a steroid with or without the low molecular weight heparin? So your thoughts on that?
I think as we earlier discussed, the main protocol would be probably D-dimer based. So on the day of say symptoms, I would do a D-dimer and see whether the D-dimer is high. So if it is high, definitely I would give a therapeutic dose of anticoagulation. But if it is not very high, then especially if it's an elderly patient, if there's a history of a malignancy, or if it's a bedridden patient who is not being very mobile, then I would advise him at least for DVT prophylaxis, that is that 0.4 milligrams, which we give 0.4 ml once a day. That is a prophylactic dose for a DVT prophylaxis. So especially if it's an elderly patient, not very mobile, not moving around, especially malignancy, history of malignancy, or renal failure, or some say prothrombotic state, or history of DVT in the past, history of pulmonary embolism in the past. So especially those patients, I would definitely like to give them anticoagulation. Antiplatelet, normally post CABG patients will be on some antiplatelet like aspirin, clopidogrel, or some other Brilinta, something of that sort. So those things should be continued. They should not be stopped. So for post CABG, I think when it comes to low molecular weight heparin, we normally prefer it in the in-hospital setting. But when it is on outpatient clinic setting, the dose is normally given is Eliquis, which is 2.5 milligrams twice a day, or dabigatran, which is 110 milligrams twice a day. So one of these NOAC can be preferred. When it comes to steroids, I don't think we should start it on day one, because the first 5 to 7 days of fever is basically viremia. So the inflammatory response has still not set in. It is all viremia which is there. So first 5 days of the infection, as Dr. Dhruv also rightly pointed out, it's all viremia which is causing the fever, the symptoms of the viral illness. So in fact, if you give a steroid, you are going to worsen the viremia and increase the viral load. So first 5 days, I would definitely avoid the steroid. I would especially go after 7 days, do an inflammatory marker. If the inflammatory markers are high and that shows hypoxia, especially hypoxia, because till now, whatever studies have been found to have effective is in patients who are oxygen dependent. If the patient needs oxygen, your oxygen saturation is less than 90%, and you need oxygen, that is the stage when the steroids have been found to be helpful. So if the patient is hypoxic, then yes, then I would definitely prefer a dexamethasone. As of course, oral, you may prefer oral or IV, and you will need to monitor them for the side effects as well.
All right. This next question I will keep open to whoever wishes to ask. We've had this from more than one audience members, our physicians. They ask about the anticoagulants. Which one is better, rivaroxaban, dabigatran, or apixaban? Any thoughts on this in terms of these are medications that I rarely have to use, so I would really look up to y'all for answers on this. Many of these I know the answers, but this one I really would like your inputs on when to consider these in different situations. Anyone who would like to take it?
I think
let it go to the cardiologist.
So for sure, cardiologists are the maximum prescribers of these drugs. We are very careful of using all these drugs because there is no strong data on patients who have a compromised GFR. What is the dose adjustment? Monitoring becomes very difficult because most labs would not be able to measure the anti-10A levels. So we are a little reluctant to use these drugs. But yes, they have been used in nephrology patients. But maybe Ameya can share his thoughts on these.
Sure.
I think a prescription of a particular drug would depend on a lot of factors. The number one is the risk profile, that is compared to thrombosis risk and the bleeding risk. So normally we have a scores, what is called CADVAS score for atrial fibrillation, which you calculate and know what is the risk profile for atrial fibrillation. But this setting is clearly different. Here it is a viral illness. So probably I would just go by the D-dimer level as we initially discussed. There is something called as a Has-Bled score, which also gives you a bleeding risk of that individual. So especially if you have a criteria, for example, a lady who is more than 75 years of age, her creat is more than 1.5 and her body weight is less than 60 kilograms. So out of these three, if two are present, the dose of Eliquis becomes half, 50% less. So as per the trials which have been studied, particular doses have been studied in particular subset of population. So if you go for the full therapeutic dose, which we give for treatment of any embolism case, so rivaroxaban will be 20 milligrams once a day with food. Eliquis will be 5 milligrams, that is apixaban, will be 5 milligrams twice a day, and dabigatran will be 150 milligrams twice a day. If your creat clearance is less, I think there have been only two drugs which have been studied. One is the rivaroxaban 15 milligrams, and the other one is Eliquis, that is 2.5 and 5 milligrams. Both dosage have been studied. In patients with severe renal dysfunction, that is less than 30 GFR, in fact, no drugs have been studied. So recommendation currently is only with warfarin, especially when it comes to atrial fibrillation prophylaxis or stroke prevention. But now there have been studies where in patients of renal failure on dialysis have been given Eliquis and they have found that the stroke risk has come down. So currently the recommendation for especially patients on dialysis is Eliquis or apixaban is the recommended drug, 5 milligrams twice a day. Now again, all these doses which we discussed is basically therapeutic anticoagulation. But as we discussed earlier, we want to give prophylactic anticoagulation. So here the doses is definitely lesser than what we recommend for therapeutic. So here the rivaroxaban 20 will become 10 milligrams. The Eliquis will become 5 milligram, which is BID, will become 2.5 milligram twice a day. The dabigatran, which is 150 milligrams BID, will become 110 milligrams twice a day. Again, as I said, in cardiac patients, they will be on dual antiplatelets. So a lot of patients will be on aspirin and clopidogrel. So we will be very, very concerned about the bleeding risk, because with 3 agents which can cause bleeding, it is always safer to stop the aspirin and continue only with clopidogrel. Normally, that also recommendation is now almost only for 6 months where patients have undergone an angioplasty or a bypass. So after 6 months, we recommend that we continue only a no antiplatelet. So here in this illness, we may apply the same guidelines which we treat for atrial fibrillation, because we don't have so much strong data. The good thing is that in these cases, we are not using antiplatelet. We are using only anticoagulation. So I think we may still get away with a low bleeding risk and proper therapeutic effect. However, the recommendation is that if you are elderly and there is a history of bleeding, see the bleeding risk by the Has-Bled score. If the Has-Bled score is too high, then you will have to counsel the patient, see whether what is the recommended dose which you will be able to give, whether you should reduce the dosage. Or you may also use something like DVT stockings or non-therapeutic, non-pharmacological approaches like DVT stockings, pneumatic pumps, something of that sort. Because the main thing will you be worried is about the DVT and the pulmonary embolism. So if you prevent that, I think majority of the thrombotic complications are taken care of.
Great. I think that's very detailed and clear. It should answer our physician friends' question. There's another very interesting question that has come up. If favipiravir is started in a suspected COVID patient and the patient becomes negative by day 5, should the treatment still be continued for 7 days or should it be stopped?
Should I answer?
Please go ahead.
We were the part of original Glenmark trial where the protocol was 14 days of favipiravir. Even the same protocol was there in Japan and Italy both. So the day on which the patient becomes negative, even in trial the drug was stopped. So frankly speaking, the drug has to be stopped the moment patient becomes RT-PCR negative as per the trial. You don't require to give it. As far as our protocol is concerned, we generally don't give for 14 days, and that's why I drew the attention of the audience initially that all the trials of favipiravir depended usually on clinical outcome or clinical improvement. So if the patient is afebrile for 3 days, for the 72 hours, his oxygen saturation is maintained for 3 days, and his walk test is fine, then and his respiratory rate is less than 20, then it is time that you can stop favipiravir at day 5. You don't need to give it for 14 days.
Great. I think it's a very clear and crisp answer. The question, Dr. Gadani, this one is for you. If anticoagulants have to be used in a patient who has comorbid epilepsy along with their COVID-19 infection, is there any preference for any particular anticonvulsant in this situation?
Yes, absolutely. The various anti-epileptic drugs has caused to cause an enzymatic either inhibition or it cause a cytochrome enzyme excitation. So those anti-epileptic drugs that have action on the cytochrome that acts on the metabolism of other drugs should be avoided. In these patients who are already anticoagulant, I would prefer levetiracetam, lacosamide, and as well as the valproic acid that has the less interaction with the other medication. So these patients must be considered if having any epilepsy. These are the common 3 drugs, that is levetiracetam, the lacosamide, and the valproic acid, which can be considered in this kind of patients.
Great, thank you. Another question, any reports of anaphylaxis to remdesivir that any of y'all have come across in any case reports or any kind of studies? Anyone can take that.
So there is the package insert of remdesivir sort of insists that the physician should be present at the time when the remdesivir is given. So that's a protocol that we follow at our hospital. The first dose of 200 milligrams is given in the presence of physician. There have been some cases of anaphylactic reactions, anaphylactoid reactions, so slightly milder, but definitely documented. And that's the reason why we have to be careful. So no drug, as we all know, and this cannot be elaborated more by anybody else than Sitesh, that every drug can possibly cause anaphylaxis and you have to be careful. But remdesivir for sure needs to be monitored, and the physician has to be present at the time when the first dose is started, for sure.
Completely agree. And as you rightly mentioned, it has mostly been anaphylactoid reactions that have been described, not classic anaphylaxis yet. And as with any injectable drug, I think the precaution when you're starting and in the first few doses of monitoring the vital signs, oxygen levels, blood pressure, makes sense to do so that you don't run into some kind of a adverse reaction. The next question that comes up, should remdesivir be repeated if CT findings persist and the patient becomes RT-PCR negative with all blood parameters being negative and the oxygen level still being above 94? Would there be any benefit to continuing or repeating remdesivir? I think the answer to this is very clear. If you have no evidence for viral shedding or active viral function, there is no role for remdesivir. But if anyone else thinks differently for any reason, for anything they've seen, then we can certainly get that answer. Yes.
Yeah, just one point on the duration of remdesivir. So it has been used from anywhere from 5 to 14 days. The minimum duration is 5 days, but people have used up to 14 days. And that really depends on the severity of the illness, what kind of patient you are faced with. But in the absence of markers, in the absence of symptoms, and especially if the COVID is negative, there is really no role of remdesivir in a late onset kind of stage. Yes, upfront, you can give it for a longer duration if you feel that the patient is sort of continuing to linger on and has manifestations of the COVID. So that's my only comment.
And I think that the point here really is that the CT findings, as we already discussed, as Dr. Dhruv mentioned, can take up to 6, 8, 12 weeks to settle. And the CT findings are definitely not a reason to give remdesivir. There's no active virus. This is post-inflammatory changes, post-viral infection that are there. It will take some time to resolve. And that needs to be managed conservatively, as we've already discussed in the previous part of the webinar.
9 o'clock.
Should we give aspirin along with low molecular weight heparin?
I think Ameya already answered.
Yeah, I think, yeah.
Currently, no recommendation on aspirin.
Yes. Okay.
So it's a weak antiplatelet, and here we are thinking of a clotting stage. So there's slight difference between clotting mechanism and antiplatelet mechanism. So it's totally different. So currently, as far as I know, there's no recommendation for antiplatelets in COVID.
I think this completes most of the relevant questions that we have gotten. There's one interesting one, last one that we'll take. We're already at 9 o'clock. A patient with fever, RT-PCR negative, mild upper respiratory tract infection, normal oxygen saturations, normal HRCT. Age is 50, D-dimer is 1800, IL-6 is 26, CRP is 30, ferritin is 840. What should be the approach? Interesting.
Repeat the COVID.
Exactly.
I just had a case in my clinic the other day. It required 4 times RT-PCR. The 4th time it was positive. And obviously in between, had they been under my care earlier, we would have probably done an antibody test. It would have come, because we do see antibody tests becoming positive even by day 6 or 7 sometimes. And it's very beneficial to get a positive IgM or get a positive antibody test to know that you're on the right track and take all the right decisions with regards to drugs and treatment. So I think, but this is important that the RT-PCR, as was mentioned earlier, has a sensitivity of 68 to 70%. The rapid antigen test, according to some, is lower than that also. So I think all the tests have to be used, and it's ultimately our clinical judgment and our clinical assessment of the patient with what they're presenting with, what their lab profile looks like, and what their problem is, that should determine what we treat in these cases. So again, I would like to thank all our panelists for a fantastic webinar with a lot of good insights. I think we have learned a lot this evening. We've had some very good interactive questions. Each one of you all are masters in your field and have really demonstrated it here today in sharing with our audiences all that they can do to protect their patients during the complications that this SARS-CoV-2 virus is creating in our patients' bodies, and also for the post-COVID complications on what can be done in managing them and following them up in a careful, protocoled manner so that we don't miss anything. And if there is something that can be treated, we do the treatment in a timely and organized manner as per the latest current guidelines and recommendations, which, as we know, keep changing every week or 2 weeks. And as Dr. Dhruv has mentioned, this is a 9-month-old baby. Generally, 9-month-old babies are very happy. I'm also a pediatrician besides being an adult allergist immunologist. I do both. But this baby certainly is growing fast, and we are learning a lot about it. And hopefully we'll have, there's a lot of interesting stuff happening in the world. They've come up with an antibody fragment that is 1/10 the size of a routine antibody that is working amazingly well in mice and hamsters. We still have to see whether it will work in humans, and if it is given early enough, might even be a nasal spray that can be given to patients early in the infection for prophylaxis and treatment. So there are all kinds of fascinating research that is going on around the world. There are clearly monoclonal antibody therapies that are being done, which can target more than one aspect of the SARS-CoV-2 virus, and we just have to keep our fingers crossed that some of these successfully clear the phase 3 trials. So do the vaccines, and hopefully we will have fewer and fewer of these webinars then, because we'll be doing a far better job in preventing the disease rather than trying to bring our patients out of the complications. Once again, thank you very much to all of you all. If there are any parting comments that you all would like to give our audiences, feel free to do so. I truly appreciate all of y'all's time and knowledge that you all have shared so well with us today. And thank you very much. And thanks to Hetero Pharma for organizing this. They have come up with some very unique topics. This is my 6th or 7th program that I'm doing with them, moderating the entire range from pediatrics to adult to pulmonary to ocular, ENT. We've done it all, and this surely was one that was very timely and needed. So thanks to the entire Hetero team for planning and organizing this and getting us all together today. Thank you.
Three cheers for our moderator.
Cheers for the moderator. I was just going to say that. So,
thank you.
It's been a long time, but good to see you, Sitesh, again. So.
Same here, Jatin. Same here.
Okay. No, nicely conducted.
Thank
nicely
you.
Moderated.
Thank you.
Does anyone from Hetero want to comment, or we just close the session?
I think we can close the session. Great. Thank you. Have a great night.
Okay.
Take care. Stay safe.
Good day.
Bye-bye.
Bye.